Good afternoon, everybody, and welcome to our third RM Partners webinar. It's great to have you on the call. Sorry for the slight delay in starting, but because of that, we'll get straight into it. And my name's Elaine Tomlins, and I'm a consultant nurse based at the Royal Marsden Hospital, and it's my pleasure to introduce Dr. Richard Lee, who's going to take us through the first presentation. So, Richard, when you're ready, share your screen. It's just coming through. And let us hear what you have to say. Thank you for coming.
So hopefully you guys can see the title screen there. Apologies for the title. I can move this in one direction or the other, sort of lung cancer early diagnosis screening or a bit of AI and things as we go. Let me just see, can everyone see that nice and clearly?
Yes, it's looking fine.
Good. So my name is Richard Lee. I'm a consultant respiratory physician at the Royal Marsden. I lead on early diagnosis, and so you may have come across me before in that context, and I also have an interest in AI and as Chief Research Information Officer, informatics, and I have an NHS England and an NHR early diagnosis role as a kind of conflict of interest. So I think the first thing to say, and you may have already come across this, lung cancer is clearly an area of priority when it comes to cancer outcomes and early diagnosis. This is a nice graph to kind of summarize in real terms what people are thinking about when it comes to achieving that goal of 75% of early diagnosis by 2028. So the average stage of cancer diagnosis at the moment is about 50% of them are early stage. And we're trying to get over here to this red line of being 75%. And the dots on the graph show how many of those cancers are already here. So sort of breast cancer effective screening program and things like some bladder cancers are already at an early stage when they're diagnosed. And this y-axis shows you the sheer burden of cancer. And you can see these sort of big cancers up here. So lung, prostate, breast, and colorectal are the kind of the more intense cancers in terms of the burden on service. And so lung cancer being over here with a very low number of early stage diagnoses and a very high number of cases really is something that we need to pay attention to. So just to recap that, I'm pretty sure you'll all be aware of that section of the NHS long-term plan, but that's where the early diagnosis concept really was set in stone in terms of it being a national political target. The community has existed for quite some time before that, but we've really seen a sort of a growth in the impetus now in terms of funding opportunities and clinical innovations that can follow that. Just to check, I can't see on my screen if anyone has their hand up or anything. It'd be really great to be interrupted as we go. Really happy to do that. Elaine, can you sort of make that known if someone asks a question like that? Are you chairing?
I'll keep my eye on it.
But I literally am very happy to stop and talk through individual styles. I think that's one of the questions. Sorry, I think that's one of the problems with talks now, that we're so Skype focused that it does become a bit like a very formal presentation. But please do stop me if there's something you want to look at in a bit more detail. So I think one of the other things that happened around the time of the long-term plan and when lung cancer screening really had a big opportunity in this country was when the Nelson study announced its initial findings. And so this is the graph you may well have seen that compares the outcomes in the patients that were in the control arm of sort of chest X-ray follow-up versus a screening arm of low-dose CT scans. And you can see there was a 26% lung cancer mortality reduction in those patients purely by undertaking the CT scans, which then makes up early lesions and leads to more effective treatment. There are defined criteria in terms of how many pack years of smoking history that they would need in there. And there were about 16,000 patients randomized, so it's a large study. See, one of the challenging things with screening is that you do need very large numbers of patients as a randomized trial to see the outcomes that you need. And so this is, it's quite an intense thing to improve and to prove in the research setting. And the mortality that was demonstrated there is lung cancer mortality as opposed to all-cause mortality. So it's quite hard to see enough of an effect size with this size population to account for all of the things that people in this age group would suffer from. The other thing to bear in mind is they've sort of justified this to say, well, it was only really sort of men that were the dominant smoking population in that cohort, and there were some women brought into it, but the female participants are very much underrepresented in this group, and there's some suggestion that they may in fact benefit to a greater extent, and it's important to remember that looking at other studies out there. Just trying to advance the slide. There it goes. So just to give you a feel for timelines, in the US, back in 2011, this study was published. So when I started my training, I remember in one of our sort of early journal clubs, somebody presented this paper to say lung cancer screening with low-dose CT was a good idea. It's another randomized trial, 50,000 patients. And again, lung cancer and all-cause mortality was reduced by lung cancer screening. And following that, the United States Preventive Services Task Force said we should do national lung cancer screening in the US. So sort of 10 years ago in the US, that was already happening. And you can see what it took in Europe for people to be convinced by that was further studies, randomized trials across Europe, so the UKLS, and then some other Danish and Italian and German studies had to come together before people were kind of convinced enough. And it was only really over here when Nelson published that we really saw that tipping point towards NHS funding for this. There were some early pilots in Manchester. Some of that was backed by charity funding, and some of it in terms of devolved government funding. The Leeds pilot study funded by Yorkshire, the lung cancer charity there. Similarly, sort of all coming together then towards the time when we were trying to kick this program off in the UK. There have been a number of position statements that it's worth going away to look at if you're interested in this area. So an ERS white paper and another European position statement that sort of highlighted what the challenges were. So what does this look like in the UK and on our patch? RM Partners is quite fortunate to have had one of the earliest pilots prior to the national program launching. It's now been absorbed into the main national program. So we have the phase 1 and 2 parts of this, and that's about 20 sites. When it first started, there were 10 geographical areas that were picked on the basis of the highest lung cancer mortality. And then the original pilots, such as those in RM Partners of Manchester, were then onboarded to make sure that we were following the standardized protocol. Broadly, eligibility is based on patients that have been, or participants rather than patients that have been smokers or ever smokers in the age range of 55 to 74 for their 75th birthday. They would come along to a truck like this, parked in a supermarket car park. Some of them are fixed site scanners, but most of them are mobile units. They would, at that point, have a lung function test. They would meet an expert lung health check nurse who would then undertake a risk score, either the PLCO or the LLP, to establish what their risk of lung cancer might be. And that's a way of targeting these lung health checks to only do the CTs in the patients with the highest risk of lung cancer. It's interesting that this has been picked up. One of the things that's evolving in screening more generally was the Richards report, the independent review of adult screening, that's suggesting that probably this sort of idea of targeting screening to those at the highest risk is probably one of the most effective ways of delivering that. We don't really see that so much with things like breast screening and cervical screening that are sort of just broadly age-based, but the idea of thinking only those with the highest risk of lung cancer should be subjected to the CT is something that I suspect we'll see in other screening programs as well. So again, the slide's a bit slow to move there. There it goes. So this is what the program looked like in the phase 1 and 2 part. And so you can see, I think this is a nice example of a national NHS England initiative that's spread throughout the different parts of the country where it's needed. I think in particular, if you compare the dots where these different lung health check sites are with this map of deprivation, you can see that the areas with the highest lung cancer mortality and where these programs have been installed overlaps very nicely with those areas of greatest deprivation. So I think that's important that we're taking these clinical innovations into the areas where they're most needed. The sort of the latter components of there, you can see we've got the research studies alongside, but we've got places such as the Hillingdon, Hammersmith, Salford and Manchester, and sites such as that are being incorporated as part of the phase 2. And all of these yellow stars are sites that essentially have now opened and are scanning patients. So broadly thinking about what this looked like before we started, I was thinking there'd be an eligible population of approximately 1 million patients going through GP records, of which half or so would have smoked. You then expect about half of those in good circumstances to turn up for a lung health check. And then once you've done the risk score, again, about half of those would have a low-dose CT scan. And then you can kind of cascade through that the number would have indeterminate or abnormal findings. And that's got quite a decent number of lung cancers that we're finding there. And that's on the phase 1 and 2 part of that. Obviously, the number of people that turn up for the lung health checks can be variable and can vary by demographic, and these are sort of modelled numbers in terms of those that have smoked. But you know, it gives you a feel for the scale of this program. If you think of sort of other initiatives you've taken part in or research studies, this is a very large number of patients, so 140,000 CT scans at that point. We have sort of dashboards of data starting to come through, and it sort of highlights one of the challenges of overseeing a program like this. So 100,000 patients that have been invited to a lung health check so far, 30,000 have accepted, but some of these numbers will be more lagged. This number is easier to measure, and this one will come in a bit later. And again, some of the numbers that attend and the scans performed come in a bit later still. So these numbers are starting to trend up quite nicely. And again, please don't share that onwards further if anyone's on Twitter. So now what we also have is phase 3 is in the process of being announced. That bring another 15 to 20 sites on board, and so those sites are aware of who they are. And what's going to be really interesting here, we've got sort of the original experts, so RM partners, UCLH, Leeds, Manchester, Nottingham, that have been doing this since before the NHS England programme started, and then the phase 1 sites that were somewhat unaware about how to do this at the start in sort of 2019, 2020, that now have all opened or started doing this, and how we sort of share that expertise in sort of delivering something that we know in the research setting works, but we're trying to understand what that means in the kind of the more everyday NHS setting. And so these new 15 or 20 sites, we need to work out how do they work closely with these existing sites to try to double the size of the programme, and so that'll bring the eligible population up to 2 or 3 million, and again scaling up on all of those number of CT scans and number of cancers that we're expecting to find by 2 or 3-fold. And then ultimately, you know, the anticipation is that we will achieve national coverage of this. Screening programmes are overseen by the National Screening Committee, which is part of Public Health England. And so there's another piece there trying to understand how do we interact between the NHS England pilot and the Public Health England National Screening Committee, and we have close interaction between ourselves, the sort of more senior clinical leads across the kind of the community and NHS England, and then the Public Health England figures. There's also the bit about sort of thinking about when you're setting up some sort of service improvement project. We had to do the same on a national level. So as we were recruited to the programme as joint leads, this document was being pieced together by 10 or 20 screening experts across the country. And so if you haven't seen this before, it's quite an interesting document to read. It's admittedly dry in parts, as it has to be, but actually can teach you quite a lot about how to run a lung health check and screening. And it's essentially a recipe book of how to do that. And you'll see things in it like this that essentially say, okay, if you get an abnormal screen, what you have to do with that in terms of referring to the MDT. What about an indeterminate nodule? When should those nodules be followed up according to BTS guidance? Where does volumetry fit in? And then the patients that then come back for a 2-year scan, even if they're completely normal. So the idea is you would scan these patients every 2 years because other cancers can appear in that interim time. This is delivered through a cancer alliance structure at present, and so at the outset that was 70 million, and that funding will increase for this latest part of the expansion, and that'll be funding that will need to continue in the future if we are able to do that. And obviously there then needs to be a quality assurance part that's essential for screening programmes in terms of Public Health England. We're not quite there yet, but we have defined our own quality assurance standards to make sure that the kind of the infrastructure is reliable and robust, both in terms of the patient management part, the clinical management parts, the IT systems, reporting, and how our lung cancer is then referred on. And obviously this is a huge opportunity for research, and then we just define some documentation about how we can do that reliably without compromising the clinical pathway. So the other things that are going to be important as we get towards this next phase and in future is how we account for workforce planning. We'll obviously need more in terms of radiology reporting capacity and diagnostic workforce. There needs to be better IT systems to support the kind of the call recall systems. There's a risk calculator that works out this risk of lung cancer, and so as these become sort of more digital, we need to think about the MHRA, and then coding is another important thing in terms of knowing what the data is that's coming from this system. Just to kind of broadly give you an overview of what research looks like here, you can essentially look at any bit of the pathway to do research on. And we've got a number of consortia coming together on this. A lot of people are interested in over here with the radiology reporting and AI. There's a lot of interest here in biomarkers, but actually some of the stuff that's easily as, if not more important, is the economic evaluation and how we ensure this is valuable as we go forwards, and particularly the patient experience and the behavioural research that's necessary to underpin making sure that the way we describe and design these screening programs is done in a way that people want to come to. Because if not everyone comes that's invited, that's a real risk for the success of the program. So this is one example of the DART and consortium led from Oxford, and I'll be leading on the blood biomarker part of that, which will be called the SCOOT study. So that'll be about 5,000 patients of blood tests. The AI part will have 100,000 patients trying to work out if you can delineate when a nodule or other indeterminate finding is likely to be cancer or not, to try and stratify that biopsy. And this is a non-interventional study, but very interesting. I'll touch briefly here to say we're doing some other research on incidental lung nodules. I can talk about this more afterwards if helpful. Just check how we're doing for time. For those that are seeing incidental lung nodules, there's quite a lot of work going on in RM partners to try to define this pathway. The national guidelines are there as by the BTS, and they're largely quite straightforward to kind of navigate through. If you have a single baseline scan or if you have a subsequent scan, see is the nodule growing? Does it have a score by the Brock or the Herder models on the PET scan to see what the likelihood of cancer is, and then whether you would biopsy or not? But this isn't always very standardized across different patches. We don't always have volumetry software in some places, and there's increasing interest now when trying to understand how we can use AI to inform this risk of malignancy. And so we have some local PhD projects looking at this, and there are also a number of companies out there that are trying to understand the space. And essentially what they do is they try to identify the nodular area on a scan and break it down into different features, which are kind of essentially things that are more detailed than just saying the nodule is this width or the nodule is this sort of size, but working down really in detail, how do these appearances look if you were to give them sort of computational measurements. The other thing I think is interesting, we've been looking at, we've got a paper you can find in Frontiers in Medicine on this, is the reports are relatively standardized. And so if you think about your own practice, how you're following up the CT scan has been done, has it been reported, there's probably quite a good opportunity to think, well, what about the text that the radiologist is using? If we can apply a sort of AI or natural language processing to that, can we find a way of sort of identifying these scans more easily when they're abnormal and flagging those for review by the clinician? We know we're getting there with the imaging interpretation and being able to kind of think about how likely it is to be cancer, but just in terms of purely being able to identify these scans for research or being able to flag that patients need to review more quickly, there's probably quite a lot of information in the report that we could use as well. And this is just one example of how we've used that data in our centre, that for all the patients with lung nodules, we found thousands of them, and be able to delineate whether these are patients with, so all of our patients in this particular cohort have previous cancers, but whether we could try to work out how many of these are likely to be metastatic disease and at what point in the patient pathway that's defined. So I think we're going to see a lot more of this sort of big data and informatics approaches as all of our systems become increasingly digitized. We'll be able to know a lot more about where these patients are sitting in our system. So, if you think about your own practice, think about the lung nodules you know about, how are they tracked? Are they tracked in a dedicated system? Are they tracked in a spreadsheet? How many of those that are operating in your hospital, how do you know where all those nodules are? And then how can we describe that data in a more sort of automated way? And I think the other thing that's important there is sort of in our setting, then sometimes those nodules aren't metastases, but new lung cancers. And so we can then start to kind of look at that in our setting by trying to think about the patients that actually have gone on to have a second cancer. And that's also relevant in the context of lung cancer, that those are resected are at potentially a higher risk of a second event. So we're obviously following some of these patients up by varying degrees of intensity. We tend to do quite a lot of CTs, but some centres will favour, as the evidence isn't so strong for CTs, chest x-rays. But at what point does those patients who might be eligible for screening become an opportunity to think about, well, the patients that have been treated for a lung cancer, could they get a second primary cancer? We should be following up their overall surveillance by a sort of a low dose CT in the future to look for a second primary cancer. I think the other thing is sort of thinking about the diagnostic pathway. There are a huge number of patients coming through the system that everyone will be familiar with how hard it is to cope with those in the timelines that are recommended in the optimal pathway. That's another great document to kind of really be familiar with. But if you sort of think about these things about direct access to CT or kind of straight to test. What are our feelings on whether the GP should be able to request that CT scan, and who would safety net that? What about when the patient comes for a chest X-ray? How reliable is your centre for getting that reported, or for getting the patient straight round to the CT scanner when it's abnormal? And so we're thinking about things such as radiographer reporting and kind of more efficient pathways will be important for faster diagnosis of those patients. And we know that if you look at the survival curves for these different sort of T1A, T1B, T1C lesions, just that kind of millimeters difference can have an impact on survival. So even faster diagnosis is likely to be important. There's one good example there. The RadioX trial will be a good place to look for radiographer reporting if anyone's interested to know the impact that has. I might start to kind of slow down a bit there just in case there are any questions, and I'm just getting slightly anxious, getting too close to Candice's talk that we've not directly compared notes on, so apologies if I have. There'll be some other things. I think you're going to see more and more of AI triage and things. I think GP risk stratification on symptoms isn't quite there, but I think could well be in the future. If you imagine combining different symptoms into a risk score and then trying to work out who should be referred onwards quicker could be quite interesting. I think just the quality of that data isn't quite there yet. And then I'll probably just touch on this bit. So you're going to hear more and more about Galleri and Grail. I think we're going to see these blood tests coming through, which help us to find in the right settings those patients that have a cancer that we don't need to do the screening scan first. The difficulty is a lot of these is the early stage disease. We're not quite sure how reliably these will perform. So the stage 1 sensitivity will remain poor. Stage 2, the hope is it might be good enough in enough patients. And certainly if you can move some patients from stage 3 to stage 2, stage 4 to stage 3, that has an important opportunity to make a difference there. I'm in danger of drifting off remit, so I'm going to skip past. There's an important point to make that lung cancer in never smokers is an important cause of cancer deaths, and the screening doesn't currently cater for this group. And so I think we really need to think about those patients in whom the typical traditional risk factors may not be apparent. And so that slide will skip, and then just say thanks to many people that are working towards early diagnosis in lung cancer, and do reach out to us if you have any research or clinical interest. It would be great to hear more from you. Sorry, that was
so much.
Hopefully I've saved some time for questions.
Oh wow, I mean there was an awful lot in there. Wow. Do come back on camera, Lorna and Candice. There's a couple of questions come through. I think you might have answered a couple of them towards the end.
Sorry, see any questions or anything as they're popping up?
No, it's on a different system. So
yeah, great.
So just for clarity in my own head before I ask the question, circulating tumour cells and liquid biopsy, they are interchangeable terms, are they?
Ish. So liquid biopsy is taking a blood sample to try to make the diagnosis, and there are various ways of doing it. The most commonly used way of describing that is ctDNA, and so that's when you get a fragment of the cancer, the DNA. So if you've come across it also is very similar to the Harmony test. So if the mother goes and you see the fetus's DNA in the blood, it's the same. If you find the cancer DNA in the blood, you know that there's cancer there somewhere. There's different ways of thinking about how that's used. The oncologists use that to say, is there an EGFR mutation in the blood that we can target? In the diagnostic setting, we're trying to say, is there cancer? And that's harder because there's less cancer secreting into the blood in early stage disease. Circulating tumour cells is when a bit of cell breaks off and you detect that cell. There are some research groups looking at that. It's probably a more difficult thing to do versus the number of companies looking at the DNA at the moment. But anything you find in the blood that could be from the cancer, people are really interested to know, is that a signal to suggest there's a cancer there somewhere that we just need to look in more detail? The blood test might replace the scan in some settings, and then once you've got the blood test, you then go onto the scan. But we don't yet have the evidence to say that.
No.
Yeah.
Okay. Couple of things then that's come through. How often do you do the screen? I think you then said it's every 2 years, was it?
It's every 2 years. It's a challenging area. So if you do the screen too late, you pick up more later stage tumours. And so we're not quite sure if it should be every year, every 2 years, or every 18 months. The programme as it's defined at the moment is every 2 years. If you're being really clever, you might argue, well, the first scan should tell you something about how likely it is you'll find a cancer on the next scan. You could do that with AI or different modelling. We've not quite mastered that yet, but in theory, and even a blood test, there are studies out there that suggest if you take a blood test, you can predict how often you should do that follow-up second scan to get the cancers at the right time. But if you let the scan go too far out, the message is that the cancer could get bigger. So if you compare, like the Nelson, if you go away and look at the Nelson study, you can see what was the scan interval and what was the stage of cancers they found as the interval gets longer. And if you let it go too long, the cancers get bigger.
Okay, I know things are rapidly evolving with AI, but we have had some challenges, haven't we, with screening programs and AI or automated results. Are we quite confident that it is it's doable and reliable and rigorous enough in this screening program?
So I think the key thing is this is still a research tool. Nobody should be using these AI tools outside the context of research. I think there are some things that detect the nodules that we would say is not AI to the extent that, you know, there's quite a few things out there that are approved for use that technically have some AI within them for finding the nodules. But the main question people are asking at the moment is this nodule cancer? And the AI for that is had a lot of studies, but we're still to reach the point where we're confident to say we're ready to put this up against the radiologists in routine practice. So I think people are very excited about it, and there's some good studies to support it, but nobody should be using this yet in the place of the radiologist.
Okay, I've got 3 other points if you can manage it.
Yeah.
One is, given that all the screening programs that are happening now for individuals, should we really be taking a sort of an American approach where once a year we go for an MOT and we coincide our, you know, our cervix, our smear test, our mammogram, our chest X-ray, you know, stool sample? Why are we doing it very
I mean, that would make a lot more sense, wouldn't it? I guess a lot of that is sort of operational and convenience. Also, the people running it are sort of slightly separated. The other problem is there's different eligibility. And so your eligibility for a breast screening program would be different from a lung screening program. But you know, there must be a better way of joining these things up, that when you go for your lung health check, people think, oh, have you had your AF screen or you know, healthy man or healthy woman check? If you're a smoker, you know, maybe you've got bladder cancer, have we thought about, do you need a blood test for that? There must be a better way of joining these things up, and I think we're starting to see some thought about that. So there's the ManVan project. It's sort of going out to the communities for prostate related cancer, and then lung health checks are also in ban. So, you know, sort of thinking about how there can be crosstalk between, you know, hard to reach populations. If there's one ban in one place, shouldn't they be asking, you know, have you received your invite for this other thing? Have you gone? Yeah. That's one of the big challenges. If people won't go, we can't, you know, offer benefit. And so, you know, just reaching the patient, if one approach can reach the patient, we should try and, you know, get as much done at the same time as possible.
For the convenience of the patient as well. What about, is there any work going on into what is protecting the 80-year-old that smoked 40 cigarettes a day all their life?
Yeah, I mean, I guess all probabilities, I suspect people would struggle to want to do research that says that smoking is you'll get away with smoking in this. But, you know, I think ultimately it comes down to it's sort of random events and sort of mutations that are driven by things such as smoking. And then each of us has got our underlying risk of getting a cancer. And actually that underlying risk is probably going to be something we see a lot more research about. So again, in prostate and breast cancer, there's a lot of interest in predicting what your risk of getting a cancer is. And if you're in the higher group, you should have more screening. And if you're in the lower group, less screening. We're not as good at that in lung cancer. It's not really clear if there would be a signal there or not. But thinking about who is most at risk of cancer and trying to triage the screening by that is probably, you know, going to be one of the future areas of sort of interest in cancer screening.
Thank you. And finally, before I ask Lorna, a couple of weeks ago on the news, there was, you know, we can now or potentially prescribe vaping. What do you think of that as a professional?
Yeah, I think so. You know, over the last 5 or 10 years, this always sort of comes up at the conferences. The official party line in the UK is it's an acceptable way to get people off of cigarettes. Nicotine addiction needs to be treated with nicotine. I think there's a lot of concern about we don't know enough about the long-term harms, and I think it's recognised it probably has significant harms. It's probably less bad than smoking. And I guess it's that balance of, do we think it's doing more to get people off a cigarette? Is it starting more young people off on normalising smoking? So I think you've got to have that conversation with your patient to say, what have you tried to deal with this nicotine addiction? Could a patch and a lozenge work? Or if they're sort of sold on the concept of vaping, then that's probably not unreasonable to go down that route. I'm not sure how I feel about prescribing a vape or an e-cigarette. Always I'm slightly dubious when I see the vaping shop on the high street, thinking that must be harmful in some sense. But I think we should all be getting together and thinking about this as a group of respiratory professionals and really advocating for the things that we think will make a difference. Do we need more research to understand what are the long-term harms? Does it work? Does it make more young people smoke? And then try and see overall how we can get more people off of smoking. And smoking cessation is a key part of lung cancer screening. That's the other thing to say. Every patient is offered smoking cessation if they smoke.
Thank you. Lorna, was anything else come through on the questions?
No, can't see anything what's come through. Thank you.
Thank you so much for joining us.
No, thank you.
Really, absolutely packed presentation. Lots to think about.
Sorry for a bit much, maybe, but it's great. Thank you all so much for listening. Candice, I'll try and catch some of yours. Apologies if I fall somewhere in the middle. But,
yeah, you're welcome to stay, of course. So I'm going to welcome now Candice, who's a colleague of yours, who's a clinical nurse specialist, and she has a particular focus on the nodules, as I understand it. So she's just going to share her screen. And we've got a little video through this, so we're all fingers crossed, hoping it's going to work. So thanks, Candice.
Thanks, Elaine. Thank you, Richard, as well. Can you all hear me?
Yes, all good.
Yeah, all good. Thanks. So my name's Candice Stevenson, and I am a pulmonary nodule clinical nurse specialist. My background initially, when I started my nurse training 20 years ago, was respiratory medicine. I then moved into thoracic surgery. I went and worked on ITU for a while, and I then moved out into the community looking after complex care patients, came back into the NHS into this role. So pulmonary nodules are found incidentally. Patients are they're just asymptomatic, and they can occur for many different reasons. Mostly the nodules are benign, but they can be the beginnings of an early lung cancer. So British Thoracic Society guidance states a patient with a pulmonary nodule need to be monitored with CT scans and follow-up appointments for a period between 2 and 4 years, depending on the type of nodule. And the respiratory team at Kingston Hospital noted that nodule patients were taking up quite a lot of face-to-face consultant appointment time, some of which were wasted as CT scans hadn't been done and patients were attending appointments without an up-to-date scan, or the patient DNA'd the appointment altogether as they felt it wasn't beneficial for them to have a scan following up something that could be benign. There was also no formal tracking system in place to monitor for any missed scans or appointments, so patients had the potential to fall through the net, really. So the pulmonary nodule service was started from scratch in November 2019 with the help and funding from RM partners, and has been running for 2 years. So the aims of the service were to convert face-to-face outpatient appointments to virtual telephone clinics, therefore increasing respiratory consultant capacity in their own respiratory clinics. A big focus was to improve patient experience by reducing visits to hospital, efficient patient tracking to ensure patients weren't slipping through the net, and to create a nurse-led service where patients have a point of contact to call, more time to discuss their worries or concerns with a link person that they get to know and that they feel they can trust. The aim was also to reduce waiting times between CT scans, patients receiving their results, and appointments. And the final aim was to introduce a dedicated nodule MDT to increase the capacity in the lung MDTs and respiratory MDTs, which were held weekly, but also to allow extra time to calculate Brock and Herder risk scores, which are a requirement and recommendation from the British Thoracic Society. So in 2 years, We've had a total of 778 patient referrals. These are mostly hospital-based and mostly inpatients or outpatients, and referrals from other specialities into us. I am starting to get GP referrals, but there are no separate process, there's no separate stream for this. So at the moment it's coming in under normal respiratory referrals and it's dependent on the consultant who's triaging them for the day. So I currently have 390 patients under active surveillance. And depending on the type of the nodule, patients are monitored for 2 or 4 years in total. And this equates to a total of between 4 and 6 appointments for the duration of their scan. I did a quick calculation before the presentation, and I've worked out the service is likely to have saved about 3,100 face-to-face outpatient consultant appointments by converting them all to nurse-led clinics. So the initial plan before the pandemic was that the one patient would see a consultant face-to-face for their first appointment, and then they would see a nurse in a nurse-led telephone clinic after that. However, the pandemic changed all of this, and the face-to-face outpatient requirements are now discussed on a case-by-case basis. As we all know, we're trying to keep down footfall in the hospital due to infection control reasons. So I also monitor patients who opt for a watch and wait approach. So it's those who do have a suspected early lung cancer, but they've opted for CT surveillance instead of a biopsy or further investigation. So in total, I've discharged 388 patients from the service over 2 years. Out of those discharged, 22.6% completed their 2 or 4 year surveillance, so they went full term with their appointments. 29.1% nodules actually reduced in size before the end of their surveillance period, so they were able to be discharged early. 7.4% of those patients, the nodules were found to be an early lung cancer. 22.9% were actually found to be intrapulmonary lymph nodes, so they're normal lymph nodes in the lung and they don't actually require CT surveillance, so we can discharge those sooner. 4.3%, unfortunately, they DNA'd 2 CT scans in succession, therefore they were discharged back to GP as per hospital policy. 3.6% unfortunately died during CT surveillance, but this was due to other causes. It wasn't as a result of lung cancer or their lung nodules. 3% moved out of the area. 5% declined further CT surveillance. Now, those patients were mostly elderly patients in their 90s who decided that really if the nodule was going to progress into a cancer, they wouldn't want to be having treatment anyway, so they opted out of surveillance. And a very small percentage, just 1.5%, were discharged under the volumetry study, which Richard touched on briefly in his presentation. So if we look at the patients who had a cancer diagnosis, there were actually 30 patients whose nodules turned out to be malignant. 3 of those patients opted for best supportive care after MDT discussion. Unfortunately, they were too unwell to carry on with any treatment. 10 of those patients went on to have successful thoracic surgery. 7 patients had radiotherapy treatment. 1 patient moved out of the area for treatment to be close to their family, so they left the district and went to live with family. 3 of those patients went on to have chemotherapy. 3 of those patients actually had cancers that were from another primary tumour site, so therefore they were metastases. And 2 unfortunately died before their treatment was able to be started. So focusing on the patient experience, which was quite an important part of the project, some telephone interviews were conducted by RM partners just before the pandemic, when telephone consultations were quite rare. And at that time, people seemed quite happy to have telephone appointments at the time. They were happy it reduced their number of visits to the hospital. They were happy they had quite a longer time to explain, or I was happy I had a long time to explain what nodules were and address any patient concerns. And as a nurse-led service, I can also support patients in other ways, such as smoking cessation referrals. Patients do like to talk about their general health concerns, I feel, more than they would with a formal physician. And I recently assisted with an occupational therapy referral for a patient as they were struggling to mobilise at home and care for themselves in general. So I was able to push that through and support them in that way. So what came out of the interviews were the comments made with the patient being deaf. So I do offer to speak to a family member if the patient's having difficulty hearing or understanding. As telephone consultations, I think we've all realised, aren't the same as a face-to-face consultation. And in the beginning, letters were hand typed, as I was very new to the outpatient process, but now all patients get standardised letters. On review of the patient information sheet, the information was very brief, which is the first one that we sent out. So I worked with RM partners again on producing the patient information video and a much improved patient information leaflet. I find it's quite eye-catching compared to the first leaflet. It's available in different languages, in Polish, Punjabi, Gujarati, and Bengali, and it matches and reinforces the information in the video. So sorry, I can't say it. So future developments for the project, we're working with RM partners on the volumetry project, which uses software to manually calculate the volume of the nodule. So this is more accurate than doing 2D CT scan measurements, especially if the nodule isn't perfectly spherical, which is often the case. So it's more sensitive at detecting any change because it takes into account all the different planes that you can measure it on. So volumetry will predict the growth of a nodule, and it means that if the prediction is that the nodule will be benign, the patient can be discharged early, and it can reduce the amount of CT scans required and the amount of radiation exposure as well. We've also got a specially adapted Infoplex program, which is going to be launched in January 2022, which will obviously, I think some trusts use Infoplex. We do at Kingston Hospital for tracking and monitoring patients. So that will make it a lot better than the current spreadsheet that we're using at the moment. And radiology are doing a pulmonary nodule CT audit at the moment. They're looking at the quality of the requesting levels on the CT scan for CTs. They're looking at the length of time nodules have been monitored for, and they're also looking at the rates of early discharge and also looking at the quality of reporting. It varies by degree by different radiologists reporting, and sometimes even something just simple as having the slice number on a CT scan can reduce the amount of time we spend in MDT trying to find the nodule on a CT scan and have a look at it. So the service has really grown over the last 2 years. I'm really quite proud of it, apart from the blip just now on the video. And thanks for listening.
So you're not a cancer nurse specialist, you're a respiratory nurse specialist. So how do you manage the sort of psychology of cancer diagnosis, and how are you liaising with the individual teams, the site-specific teams?
So I think in terms of I'm not a cancer trained nurse, and the only experience I've had is by coming into the lung cancer nurse team, who actually have been incredibly supportive with me starting in my new role, and the consultants have been incredibly supportive. And I've been really lucky to do the advanced communication skills course, which really, really helped me in talking to patients. I think there's a big difference between talking to someone face to face and talking to somebody over the telephone. You miss that connection between somebody, and I think it does take quite a skill. And so, yeah, I've learned a lot since starting my role, definitely.
And are you doing things like holistic needs assessment on the patients, or not? That's only if they get a cancer diagnosis, is it?
Yeah, that's only if they get a cancer diagnosis. I mean, you are quite limited to what you can do over the phone. It's almost like a formal physician consultation over the phone, really. But obviously, then if the patient does have a cancer diagnosis, they get handed over to the lung cancer nurses, and then they have their H&As done then. Yeah.
And is it somebody's written about the diagnosis? So you've got this nodule on a scan or on an incidental finding or whatever it might be, but you still need a bit of tissue, do you?
Yeah, they can do. Yes. So basically this is almost pre-cancer, my work. So these are the nodules that are found by accident. And if they grow or change in shape in any way and they cause a concern, then they would be put forward for a lung function test or a PET scan, and then consideration of a biopsy to get tissue. And they move then down the pathway.
Yeah. And also somebody's asked about, presumably, I mean, I'm putting words in their mouth perhaps, presumably there's some health promotion messages in what you're doing. Yeah,
definitely. Yeah. Smoking cessation is quite a big part. And I've also, patients do ask me, what can I do to get rid of these nodules? And there's nothing really they can do apart from try and improve their general overall health. So yeah, you do get to do a bit of health promotion at the same time.
Okay. Somebody has also asked a question about the age group of the patients where the nodules were found. Are they, do they fit into a particular category of age? Is it mainly older people? You mentioned the 90-year-olds that got lost in follow-up. But...
Yeah, so no, it's mostly, I would say people maybe around the starting 60s, 70s are the majority of my cases. You do get the odd younger one, but sometimes they're just inflammatory nodules. Obviously, we've seen quite a lot of inflammatory nodules post-COVID, so that increased our referral rate quite a lot. But then they reduced again in size on their next CT scan, and they were able to be discharged. So yeah, mostly the older population.
I guess going forward as well, there is, for instance, I had a CT scan when I was 18, but there's no way we could track that, now. No. But in time, of course, we will be able to see, whether it is truly new or whether it has been there for years, and won't we? Yeah.
Yeah, and
it'll take over. Yeah.
Yeah, and MDT, our radiologist, is very good. She looks back. We speak to the patients before we go to MDT, and we see if they've had any other CT scans in other hospitals to try and track them back as far as they go, and also to stop repeat CT scans for these patients.
Yeah. Yeah. Great. Lorna, have you got anything on your side?
There's no more question on there, but I just wondered if Candice or Dr. Lee, if you could, for perhaps people who are listening who don't know, just talk about the Brock and the Herder score, and which do you use? Do you use both? Just a brief overview.
Oh, I don't know if Rich is still there. I can talk. So a Brock score, it's a prediction tool really, that's used to predict risk of malignancy. So the Brock score is used on CT scans, and the Herder malignancy risk score is used on PET scans. That's the difference.
Okay.
Yeah, great answer. Just have a look at the flow chart, and you just nudge forwards with your patient. You think, okay, CT scan, Brock score, needs a PET scan, and then see where you end up. Not everyone uses them. Some people say on a clinical judgment we can actually kind of put the risk of malignancy at this, but mostly it's quite a useful tool. And the other point, say on the biopsies, sometimes the clinical oncologist will even treat on a Herder score. If you get that patient you can't biopsy, if the Herder score is so high, you think, well, this is a cancer, it's growing. Some of those patients they will treat with radiation on the basis of the Herder score rather than the biopsy.
Treat with radiation, you said?
Radiotherapy, like SBRT. So rather than having a biopsy, thinking it's a surgery, is it radiotherapy? For the patients where you think I can't biopsy them and they wouldn't be suitable for surgery, then sometimes they'll use SBRT without the biopsy, just the Herder score.
Okay. Isaac, how are we doing?
Yeah, we're a go now.
Okay.
Thanks, Isaac.
I'm Dr. Susanna Block, consultant respiratory physician. As respiratory physicians, we look after lots of patients with lung nodules. We know from them that when you are told you have a nodule in your lungs, it can be confusing and you may have questions. We have made this video to help to reassure you and to explain what it means to have a lung nodule. It is very common that if you have a symptom related to your lungs or your breathing, the doctor may ask you to have a chest X-ray or CT scan to take pictures of your lungs.
Sometimes a scan can be done for other reasons, for example to assess your heart or kidneys, and in these cases the doctor will still review parts or all of the lungs if they are seen on the images.
I'm Dr. Richard Lee, consultant respiratory physician. A common finding when we look at pictures of the lungs on scans is something called a lung nodule. Sometimes this is also called a pulmonary nodule, and the two phrases mean the same thing.
Finding a nodule on a chest X-ray or CT scan is very common. The word nodule describes a small, more dense area of the lung which appears as a round spot on the image. They are often small, measuring less than 30 millimeters, don't have any symptoms, and do not affect the function of the lungs or interfere with breathing. Your doctor or specialist nurse may sometimes show you your scan to help you understand what we're looking at. Here is an image of a CT scan of the chest. The areas in black are the lungs, and the lung nodule shows up as the white spot on the right side of the screen. Up to 35% of people who have a CT scan which includes their lungs will have a nodule found. Sometimes it is possible to find more than one nodule in your lungs. This is not necessarily more serious than having a single nodule. The nodule can be due to lots of different causes. These can include a small area of infection, scarring, or even normal glands within the lung. Nodules are common in people who have had previous TB. In a small number of cases, they can be the first signs of an early cancer in the lung. If this is the case, finding them early makes them much more treatable.
I'm Dr. Sarah Sheard, consultant radiologist. As a specialist in lung nodules, I look at the size of the nodule and the details and characteristics of its appearance to help decide which nodules do require follow-up or assessment and which do not. We also take into account lots of other factors like your age and other medical history. We know which nodules might turn into something worrying from studies of thousands of people's scans and their outcomes. These have helped to refine what we look at on each image and tell us what to do next with each sort of nodule.
It is not always possible to tell exactly what a nodule represents on the first scan, and in these cases we may offer you one or more further scans to see if the nodule changes or stays the same over a period of time. The process of repeated checking with scans over different time periods is sometimes called nodule surveillance or active monitoring. Most lung nodules stay the same size, get smaller, or even disappear.
If a nodule has not increased in size over a series of scans, no more follow-up is required. The majority of lung nodules do not change, but for a small number of people, we may ask you to do further tests.
A small number of nodules can develop into early lung cancer, and this is the reason that it is important to get follow-up of these nodules right. If a nodule is cancerous, it is helpful to diagnose it early, as we can offer more treatment options and we can get better outcomes. It is important to remember, though, that the general risk of a nodule being early lung cancer is small.
Your doctor or specialist nurse will talk to you about your individual risk, and you can always ask any questions if you have them. If you have a scan which shows a lung nodule, these are some of the types of clinicians who will be involved in your care.
Consultant respiratory physician.
Consultant radiologist.
Pulmonary nodules clinical nurse specialist.
Specialist trainee doctor.
I'm a coordinator for the team and I help to manage your care.
This is the multidisciplinary team, or MDT, who work together to look after you.
All patients having lung nodules reviewed will have their appointments with their doctor or specialist nurse to talk about the results and next plans. These might be face-to-face, over the telephone, or via video clinics, or through letters. If you do have worries or anxieties, especially between appointments, it's important to talk to them about this.
Lung nodules are very common findings, and your team are there to support and work with you and to answer any questions you have. If you'd like to find out more, some useful resources are linked below this video or available from your hospital.
Well, that was excellent, wasn't it? Really good, really good. Well done, everybody, for putting that together. I'm really pleased, actually, from a personal point of view, to see active surveillance. I always think the term watch and wait is really worrying for people, and so active surveillance gives a much more positive outlook, I think. Listen, thank you all for your presentations, and we've asked Isaac to put the link to that video in the participant chat in the background system. So do have a look and do use it. Or if you have any further comments or questions, I'm sure Candice or Richard would be happy to have a chat with you. So thank you all for attending, and thank you for your talks. Of course, you'll be sent a certificate and an evaluation, so please do complete them. And our next session is in December, where we have Randall Jones, who's going to come and talk to us about moral injury, which I think is really something we've all perhaps come across through the pandemic. And Sarah Lister, who's Head of Psychological Services at the Royal Marsden, is going to complement that talk. So remember, you have to sign up individually for each session, so we'll send out some invites in the coming weeks. But again, thank you so much, Candice and Richard and Lorna, for being on the panel. Take care, everybody. Have a lovely afternoon. Bye-bye.